Thanks to our chairman and co-chairman, Aymar and Vladimir, and congratulations to the speaker that preceded me, Victor Hugo, and Pablo, Igor. Congratulations, beautiful lectures. Okay, I will try to describe some important segments of this anterior, medial, and posterior skull base, especially focused for neurosurgeons in training, for residents of neurosurgery, that are very important to work on this skull base structure in the laboratory first, and then with our patients, in order to achieve to some complex skull base lesions like tumors or like vascular complex aneurysms. And I think that it is very important. But for the first message for the young neurosurgeons or for the young residents is that you need to work many hours on the neuroanatomical laboratory before to go to the surgical room and put in practice these skills that you can learn in the laboratory room. Okay. In this first slide, only for remember that the skull base can be divided in three segments: the anterior fossa, the middle fossa, and the posterior fossa. In each fossa of the skull base, I think that there are several bone structures that should be learned, and in some cases should be removed or should be achieved in order to work with tumors or complex vascular cases. For example, different tumoral scenarios where you need to manage in a proper way the skull base anatomy in different kind of meningiomas, clinoidal meningiomas, anterior fossa meningiomas, petroclival meningiomas, and another kind of tumors like schwannomas and aneurysms too. This is an anatomical specimen, of course, that we prepare in order to train our residents in the laboratory room, putting with some kind of silicone, soft silicone, in different regions, like tumors, like meningiomas, and we try to explain to our residents the correct way to achieve this kind of lesions. Some bone structures important to remember in the skull base that should be very important to work in the laboratory in order to drill it, to remove it, are, first of all, the lesser wing of the sphenoid is an important structure that should be removed in all the anterolateral approaches, like in a pterional approach, front-orbital approach, because this element, once removed, allow us to gain space to gain vision with our microsurgical corridor, okay? And it's very important to remove. The mammillary eminences of the frontal bone are very important to remove, to drill out with our drill, because especially when we need to perform a frontal craniotomy or transciliar supraorbital craniotomy, are very important to remove to gain some millimeters of space in order to have a flat frontal floor for our microsurgical corridor. The roof of the optic canal is very important to know how we can remove it, because if we need to approach some kind of complex aneurysms or tuberculum meningiomas tuberculum cellular meningiomas, this kind of tumor may grow inside of the optic canal, and you need to decompress the optic nerve. The tuberculum cella is very important too. The anterior clinoid process is very important to know how I can remove it, especially for some carotid ophthalmic aneurysms. And in the posterior fossa, the structures that are very important to know are the internal auditory canal and the suprameatal tubercle. These structures are very important because sometimes you need to remove the posterior wall of the internal auditory canal or the suprameatal tubercle, you need to remove in case of a big suprameatal tubercle in order to reach the trigeminal nerve for neurovascular compression, for example, or for trigeminal tumors like schwannomas of the trigeminal nerve. Another important structures are the anterior petrosal apex, especially for anterior petrosectomies, and the posterior clinoidal process in order to reach some kind of vascular lesions located especially on the basilar artery. Okay, for example, we have here a case where it was very important to drill the mammallar eminences of the frontal bone. Another case of a tuberculum meningioma, tuberculum cellular meningioma, important to know where the tuberculum cella is located in order to remove in a safe way this kind of tumors. The roof of the optic nerve, very important for decompress the nerve when it's related with the pattern of growing of some kind of meningiomas or for clipping some kind of aneurysm. Anterior clinoidectomy, of course, the removal of the posterior wall of the internal auditory canal are very important in order to remove the schwannomas, the vestibular schwannomas that generally are located in part, at least, inside of the internal auditory canal. And here we have the last example of the drilling of the suprameatal tubercle. Okay, we will start with the first case I want to highlight the importance of the drilling of the mammillary eminences in this transciliar supraorbital approach in order to flat the anterior fossa in this small corridor that allow us to get good access with our microsurgical corridor to clip this posterior communicating aneurysms in this special case. If we don't take the enough time to remove the mammillary eminences in this small corridor, it is difficult at least to get good visual field in our deep surgical corridor. Okay, here is an example in a pterygonal approach where the lesser wing was removed. It's very important to create a common space between the anterior cranial fossa and medial cranial fossa, removing this bone block of the lesser sphenoid wing. And here we can observe the meningorbital band. That's a very important dural landmark for our anterolateral approaches. Another example of this skull-based structure, the tuberculum cellular meningioma, yeah, located firstly in the tuberculum of the cella here, and growing inside of the optic nerve. In this case, it was necessary to decompress the optic nerve with the drill, and then to drill in order to remove the dura mater and the bone affected with the meningioma located between both optic nerves in the tuberculum cella in this location. But I need to highlight again the necessity to work in the laboratory before to operate this kind of patients. Another example of the possibility of removal of the roof of the optic canal in order to mobilize this optic nerve that were displaced by a small aneurysm in the superior carotid ophthalmic segment of the artery in this place. We remove firstly the dura mater that covered the optic roof and the falciform ligament too, and we perform the drilling of the 10 millimeters anteriorly of the optic canal in order to liberate the nerve. We gently mobilize the nerve superiorly, and then we can clip this small aneurysm instead to perform the anterior clinoidectomy that we have more risk of bleeding, of damage of the third cranial nerve, as everybody knows. And for some kind of aneurysms, like this carotid ophthalmic aneurysm, not only were necessary to remove the roof of the optic canal, we need to remove the anterior clinoid process in order to get access to the proximal neck of the aneurysm. This maneuver of remove the anterior clinoid process is very important in some cases, and it is not a simple maneuver that should be, again, achieved in a laboratory room before to operate to our patients. Another case that were important to remove the anterior clinoid process in these bilateral clinoidal meningiomas, the anterior clinoidectomy was performed in an extradural fashion, and then in the intradural stage, the sylvian fissure was splitted, and the right clinoidal meningioma was removed firstly, and the left clinoidal meningioma was removed after the left one. The objective of this relation between the importance to learn the microsurgical anatomy is to demonstrate that if you work hard in the laboratory, you can perform good and excellent procedures with our patients. In the posterior fossa, superiorly to the internal auditory canal, we have these bone prominences, that is the suprameatal tubercle, and sometimes this structure is prominent. Here we have a big suprameatal tubercle, and here we have a small. And if you need to reach to this segment of the trigeminal nerve, sometimes this structure can be in the middle of our microsurgical corridor and should be removed. I will show you a left retrosigmoid approach in a schwannoma, in a 3A classification schwannoma, where was very important to the identification of the tubing lines and the bone drilling of the posterior wall of the internal auditory canal in order to remove, firstly, the part of this schwannoma that grows inside of the internal auditory canal. We prefer to decompress the nerve firstly, and after to work to the whole tumor in order to avoid more damage with the small fibers of the fascial, especially inside of the auditory canal. The last case that I want to show you is a case of a young patient with a trigeminal schwannoma. And in this anatomical specimen, we can be highlighted in green here, a big suprameatal tubercle. And in these cases, sometimes we need to remove this small segment of bone without any danger of produce neural or vascular damage in order to achieve the more distally part of the cisternal segment of the trigeminal nerve. In this video, we perform a right retrosigmoid approach, and we can observe in the first step of the surgery the tumor, but the more anterior part of the tumor was not possible to see, and we need to remove the suprameatar tubercle in order to gain access to the anterior part of the tumor, and we can observe here the trigeminal nerve completely free of the schwannoma. Finally, in order to finalize this presentation, why anatomy? Because what the mind doesn't know, the eyes doesn't see. Thank you very much to everyone for your attention.
Right, thank you, Matias. I cannot see questions yet. I cannot agree with you more that for paraclinoid aneurysm, when they are small, it is so important to decompress the optic canal rather than the clinoid. You give a fantastic talk before. In fact, most of them, that's all it requires. The strut is not on the way apart if you have a large aneurysm or it's coming from the carotid cave, which is very rare. I do have a question to you and maybe to Victor regarding vestibular schwannomas, regarding the ICA, anterior inferior cerebellar artery, because no doubt acoustic surgeons have reported pontine ischemia with damage of the ICA at this area. That means that the postmeatal segment does not just end at the middle cerebellar peduncle or the petrosal, but it does go back and supply perforators through the posterior lateral gutter of the pons. What do you think?
All the reports said that the postmeatal segment of the ICA have not recurrent branches to the pons. And I think that in cases of large schwannomas surgery, it's very important to avoid to compress with the spatula medially to the middle cerebellar peduncle. This is very important in order to avoid the vascular damage with the spatula. But I didn't see recurrent branches in the postmeatal segment, at least in our dissections. I didn't see it.
But it has been reported, you know, from acoustic surgery that
yes.
damage of ICA.
Yeah. Yes, sir. Yes, sir. It has been reported. I don't know if it could be related with vasospasm of the artery too.
The segment, you mean?
Yeah. Yeah.
Also, as Matias saying.
Hi, Thomas.
Hi. Great lecture, which I'd like to comment later. But on this discussion, it is when there's a large tumor there, it's very difficult to be absolutely sure what was damaged, as Matias was insinuating during the surgery. One cannot be sure that any, in fact, whatever occurred was due to postmeatal segment, right? Because both segments will be in play in a surgery like that.
Yeah, for big tumors, I think that it's very important to remove the mastoid tip as much as possible anteriorly in order to gain good access in your retrosigmoid view. Decompress the tumor firstly. I think that is very important for big tumors because you are not able to see the internal auditory canal. You can see only the solid tumor in some, for example, in 4B cases. And I think that it is important to debulking the tumor in order to decompress the brainstem, firstly, to work separating the tumor to the brainstem or the middle cerebral peduncle.
Thank you, Matias. Any other questions from
Matt, I have one comment on this issue. I think most of the complication when it comes to ischemia is related to retraction. It's not because of the recurrent vessels of the suprameatal segment, but people, they don't pay attention to the retraction where the retraction. And you mentioned a good point, don't put the retraction against the middle cerebral peduncle. Now, the other things, doing excessive mastoid drilling, I don't think so. You have to be at the edge to the sinus, both at the junction of this sinus, but always start with the decompression, central decompression of the tumor. It gives you plenty of space if you are dealing with the big or giant vestibular schwannoma. I think we have a tool there. He has the vast experience. If he can give a comment on this short. Atul, are you with us? He left most probably. Vladimir, you can give a comment. You were asked to give us some comment on this.
Before Professor Gold gets ready, just a general comment. I think it was very good topic chosen by Matias, because often we discuss each of the bony bits in isolation, either anteroclinoid or jugular tubercle and so on. And it's nice to actually do this kind of overview talk, which reminds us that because certain things are there, we either don't necessarily have to take them always, or the other way around. Actually, because they are there, we don't need to necessarily work around them, because there are bits of bone, bits of dura that we can drill or remove to make the surgery safer. And this was a nice little overview showing how we can do it in water areas. Can I just ask Matias, for aneurysm surgery, do you do ever or much extradural clinoidectomy, or you would choose to do it always intradural or sometimes intradural, and when would you do one or the other?
We work by a protocol. If you have to operate an aneurysm, we prefer to work intradurally, because if we have some kind of bleeding of the aneurysm, we can control it in seconds. If I need to remove a clinoidal meningioma or medially sphenoid wing meningioma, we prefer to work extradurally in order to coagulate the vascular supply of the tumor before to approach the tumor itself.
Can I just add to it that sometimes people are very dogmatic about it, and actually it's good to kind of free yourself from dogmas always, including this area, is that you can actually sometimes work intra and extradural. For example, if you can work extradurally, but equally you can open the dural flap and look inside and look outside. You can incise the dura further away from let's say the clinoid, which is often, in fact, often the intradural clinoidectomy actually is extradural as well, because we incise the dura and then go extradural further away from the center of action.
Yes, sir. This is an interesting concept. For some kind, we have 2 or 3 clinoidal meningiomas that firstly we opened the dura mater, and then we work extradurally. We perform a peeling of the dura mater immediately laterally to the meningioma, but we see the meningioma, and we perform the peeling of the dura mater and work extradurally, but with an intradurally vision. I don't know if I am explaining in a good way.
Yes, you are. And the same thing applies to let's say anterior petrosectomy, taking the mammillary ridges on the anterior cranial fossa, any really surgery of this sort.
Yes.
So we move on for the